by Carriers are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, ladies and gentlemen, and welcome once again to the Caribbean African Targeted Health Improvement Program, CATHIP Health Hour. It's another Saturday morning. Don't know where you've joined us from, but it seems to be sunny outside where I am based. But welcome everyone, and really great to have you all for one of our another amazing sessions. Today's topic is going to be on lifestyle practices and womb cancer. And we're extremely delighted to have Dr. Joanna Abiola, who is a consultant obstetrician and gynecologist, join us to present this morning. As many of you will know, this Saturday morning sessions are designed for, people in our community, you and I, who are non-clinical, but also those who are clinical and want to learn a bit more. They're more than welcome to join. We bring you these sessions every Saturday morning in partnership between the Caribbean African Health Network, alongside our amazing partners, Rafa Development, International Development Agency, Croydon BME Forum, Enfield Caribbean Association, Black Health Initiative, and then the RCCG Royal House based in Sheffield. And we're extremely delighted and grateful to our sponsors, the National Lottery Community Fund. So we're going to have our amazing Dr. Joanna Abiola present to us for about 45 minutes. And then on the back of that, it will be an opportunity to ask questions. As you can tell, the session is very popular. And so with, nearly 180 people, we may not be able to go through all the questions, but what we want to guarantee you is the fact that if you email us, your questions or, those you leave in the chat box, then we're more than happy to come back to you. Our amazing guest speaker is happy to share the slides, so you don't need to make notes, but we need your concentration and we need you to ask those questions that really matter to you. So once again, welcome everyone, and I shall leave you, well, not leave you, I'm here, but in the capable hands of Dr. Abiola. Over to you, Dr. Joanna.
Thank you. Good morning, everyone. It's really good to have you all here. I'm just going to share my slides and we'll get cracking. So we're going to go through lifestyle practices and womb cancer. As Charles has kindly said, thank you for that introduction. I'm a consultant gynecologist. I also do obstetrics as well. And I have a special interest in the initial diagnosis and management of female cancers. So that's cancers of the womb, ovaries, cervix, vulva, and that's been my special interest for the past few years. So I thought it would be helpful to go through some recent topical issues in relation to womb cancer, and it will also be good to get your questions at the end, and hopefully I can help to respond to them as well as we go on. So to begin with, I just thought we'd go through the aims of the session. So I'll talk about endometrial cancer. That's the scientific word for the womb lining. That's the endometrium. We'll also go through some of the risks for womb cancer. I'll talk generally about how we investigate and manage cancers in the womb. And also we'll then proceed to talk about hair relaxers, because that's been topical over the past few months. There's been some really important research that has come out about it, and I thought I'd go through that. We'll briefly talk on some of the socio-political issues in relation to hair relaxers. Obviously, they're quite controversial, so I just thought I'd touch on them, and then we can discuss them if we have time. I'll touch on the research that has been produced in relation to relaxers and womb cancers. And then most importantly, and I think this is the most important thing, is to consider how we can all reduce the risk of womb cancer. So whether you're female or male, we'll all have women in our lives who can potentially develop womb cancer. So we'll go through that. I appreciate that cancer is not an easy topic to talk about. It's obviously easy for me because it's my special interest. However, I think it's important because we do know that 60% of us are going to be affected by cancer at some point in our lives. The good thing is most cancers are treatable. Lots of people do live with cancer for a long time. And I think particularly in our community, it's important to discuss these difficult topics. Obviously, I know that they are difficult and a lot of people tend to stay private about them. I do think that with more knowledge and education, we can become more powerful. We can improve our ability to manage these conditions. So hopefully this is just the start of many discussions. So please, if it's a bit triggering or uncomfortable, please feel free to mute or email if you've got any questions you'd like to ask later. So again, we'll just go back to basic anatomy from school. We've got our womb here in the lower part of the female pelvis, obviously where the baby sits in women who've been pregnant. We've got our fallopian tubes here, our ovaries releasing eggs every month. We've got the womb lining, which is here, and this is where cancers of the womb begin. And we've got our cervix, which is the neck of the womb. This opens up to allow babies to be born, and the vagina here. Outside the vagina, we've got our skin here called the vulva, between the thighs, and that's another area where cancers can form as well in the woman. So womb cancer is the colloquial word for it, but scientifically endometrial cancer, that's how we, that's what we name it in the UK. In America, they tend to call it uterine cancer, all the same. It's the fourth most common cancer in women, so that's why we're talking about it. You've got breast cancer, which is the most popular cancer in women, lung cancer and bowel cancer are the top three, and then endometrial or womb cancer is the next. We don't talk about it as much because it's not as common, and obviously I think the stigma of it, because it's internal, it's obviously linked with childbearing, periods, that kind of thing, so it's a bit more stigmatized, I think. But it's important that we address it. So nearly 10,000 women a year are diagnosed with womb cancer. Most women who are diagnosed with this are over 40 and under the age of 75. And at the moment, we don't have a screening program for womb cancers in the UK, like we have for a few other cancers, for example, breast cancer, where you go for your mammograms, where women go for their mammograms every few years, or bowel cancer, where over a certain age, you'll be asked to give a stool sample to your GP. So we'll go through the risks. I know this is a bit of a busy slide, but I think this will help with conversations later on. So the first risk we've got here is when you start your periods early, or you finish you finish your periods later, as in you start your menopause later. So essentially the background of that is that if you start your periods early, your womb lining is already being active. So for example, women who start their periods under the age of 12, there are some girls who do start early, so it means that their womb lining has a longer time to be shedding, re-thickening each month. So that does mean when they reach 40s, 50s, their risk of cancer does increase just because their womb lining has been active for a lot longer. Obesity is the biggest womb factor, the biggest risk factor for womb cancer. And that's certainly the women I see in my clinic. A lot of them will have BMIs over 30. And we'll go ahead and talk about that shortly as well. That's definitely one of the biggest risk factors that we can actually address. Some of these risk factors we've got no control over, but the ones we do have control over, then it's within our power to actually help that. Diabetes is a big risk factor as well, and I'll go and touch on that shortly. HRT use, so that's hormone replacement therapy for women who are in the menopause. That does slightly increase your risk of womb cancer as well. Tamoxifen is a drug that's used for women with breast cancer. Unfortunately, this drug also affects estrogen, so it can increase your risk of womb cancer as well. There's a genetic condition called Lynch syndrome, and that's linked with bowel cancers. And if you do have this genetic condition in the family, then you are at a slightly high risk of getting womb cancer as well. So that's important to consider too. Age, like I've mentioned before, obviously we can't modify that, but certainly over the age of 40, your risk of womb cancer increases. I made a note of conditions here because there are a few gynecological conditions that can increase your risk of developing womb cancer, like PCOS, endometriosis, fibroids. And that's because the lining of the womb has been affected by these conditions, and you do tend to get overgrowth of the endometrial cells. Those are the womb lining cells, and that can increase the risk of cancer. And those are a few conditions at the bottom there: endometriosis, fibroids, hyperplasia, that's increased growth of the cells in the womb lining, and PCOS, which is polycystic ovarian syndrome. And that can lead to a thickened womb lining because women with PCOS don't tend to have regular periods, so they're not shedding their womb each month. And then you get overgrowth of the womb lining, and that can lead to womb cancers or pre-cancers of the womb. So we'll touch on obesity. Sorry, there's a typo there. It shouldn't be $25 of adults. There's 25% of adults in the UK are found to be obese. And we class obesity in the UK as a BMI over 25. When it's over 30, there are other categories as well. So overweight is over 25, over 30 is obese. Surprisingly, 20% of children are known to be obese. And I was quite surprised at this figure because it's a lot higher than I thought it was. And it's sad because obviously children are impressionable, and it means that we have to make sure that children are developing good lifestyle, good activity, so that they can prevent the risks of obesity in the future. Obviously, we know that BMI is used as a determinant of obesity. However, obviously within certain populations, like the Black population, we know that the muscle mass is slightly higher, and that can lead to an inaccurate calculation of BMI. So actually, evidence seems to say that it's preferable to measure the waist-height ratio. And when you are measuring that waist-height ratio, it means that you have a better determinant of obesity. There are some risks with obesity. So there's some medical conditions that are linked with obesity, and that's why it's such an issue. I think it can be difficult because obviously obesity is a difficult issue. It's visible, it's linked with stigma. Some people feel it's because people are lazy or not doing much or not listening to health advice. However, it is linked with a range of medical conditions listed here. So obviously we know diabetes is linked with obesity, high blood pressure, high cholesterol, heart disease is a consequence of those two, high blood pressure and high cholesterol, asthma, cancers. So we all know that one of the biggest risk factors for any type of cancer is obesity. So managing your weight will reduce your risk of many, many cancers, particularly central obesity. So weight that's kept around your waist and abdomen can link with cancers. And the reason for this is because this weight is often linked with hormonal changes in the body. Arthritis can be linked with obesity because you are obviously having more weight on the joints, and that can lead to some wear and tear on the joints, particularly if you are older, when wear and tear is inevitable. Sleep apnea can occur, and sleep apnea is difficulty sleeping and difficulty breathing while sleeping because of excessive weight around the neck, and that can lead to snoring, sleep problems, and then fatigue, and obviously the consequences of that on a daily basis, poor performance and general fatigue. And obviously we've also got liver disease and kidney disease. So those are two other organs in the body that are affected by obesity. I've just done a quick word cloud here just to show some of the psychological and social issues that can be linked with obesity. So I'll just leave that there for a second for people to have a look at. So aside from the medical consequences of obesity, we've got to consider that obesity can really affect confidence and ability to actually get out and do exercise or do your normal activities, for example, work, family commitments. It can really affect it. So it's important that we identify it and manage it. And it's difficult. It's not an easy condition to manage. It is difficult. So in terms of management, so first of all, the basics of it are addressing what goes in and addressing how active we are. So the World Health Organization do say that adults should be doing between 2.5 and 5 hours of activity a week. And that can seem a bit daunting, but when you break it down and you think, okay, I'm going to start with 10 minutes a day, and that already gives you maybe 60, 75 minutes a week. And then you can increase it with time. So some of my patients I see in clinic with endometrial cancer, so I'll encourage them to start by doing 10 minutes after an evening meal, because the evidence out there does say that as soon as you are exercising after eating, you are reducing your blood sugars, your metabolism improves. So I start by suggesting 10 minutes after a meal for the first 2 weeks, and then increase that to 15 minutes. And then from there, you increase steadily. And it can get to the point when some women are going and exercising 30 minutes every day in the evening, and that's it. So 30 minutes every day gives you the 2.5 to 3 hours a week, and that's it, that's done. And it's fast-paced walking, cardiovascular activity, increase your heart rate, and reduce your risk of heart disease, diabetes, and obesity. So that's definitely one area. Genetics, unfortunately, we have no control over. So if genetically your family members are obese or tend to be bigger, particularly over the age of 40, that's something to address and just to consider early on and manage that. We've talked about regular activity, and it is difficult. I think the first thing is to find something you enjoy. Do it little and often and increase with time. And your GP or health centre should be able to help assist with that. I mean, now it's summertime. I know that British summertime isn't always the best, but it's a great time to start walking or light running or jogging. There's some great apps online to help with that, such as Couch to 5K. Other apps are available, obviously, but try a few different ones and see what suits you. I was looking at some of the diets and the evidence behind some of these diets and weight loss. I think two that are very popular and evidence-based are intermittent fasting, which is essentially you eat within a certain time period of the day. So for example, you have 8 hours in the day to eat, so you only eat between 12 and 8. And it means that you improve your metabolism, your blood sugar control improves, and you lose weight. So some people find that this is a good diet to do because it means it's a full lifestyle change. So when it comes to obesity or being overweight, it's all about a lifestyle change, not just doing a quick diet and seeing if it changes. So you have to do something that you feel you can stick with for life, really. Intermittent fasting seems to be a good dietary change that a lot of people find quite manageable. They wake up and they don't eat till 12. They have their afternoon meal around 12ish. They eat again in the evening, maybe like 5 in the evening, and in between maybe have healthy snacks or hydrate, and they find that they lose weight and it's more controlled and more disciplined. So that's something to consider. There's also the 5-2 diet, that's evidence-based, and that means for 5 days a week, you restrict your calories, and then for 2 days you eat normally. GPs in the area should also be able to advise on weight management programs. There's also social prescribing now, where you are offered weight management activities or activities at your local gym to help with weight loss. In some situations, when people have tried the above, there are medications and injections that people can use, and in extreme situations, weight loss surgery. I won't go into depth about that, but those are the kind of general aspects of management. We'll touch on diabetes, because we know that obesity and diabetes are big risk factors for womb cancer. So we know that high blood sugar is the cause of diabetes, and your body is unable to manage these high blood sugars, and it can lead to symptoms of feeling thirsty, passing urine too much, and excessive tiredness. Also symptoms such as recurrent infections such as thrush, itching, wounds that heal slowly, and blurred vision. Risks such as ethnicity, diabetes, ethnicity, genetics are some of the things that unfortunately we can't control, but those are well-known risk factors for diabetes. And if you do have those symptoms, I strongly suggest you see your GP. You can do a HbA1c test to see if there's diabetes. And again, management of diabetes, first of all, it's lifestyle. So many people who are newly diagnosed with diabetes find that if they manage their diet, they can manage their diabetes for life, literally just by assessing what they eat. Exercise, like we've spoken about, and in some situations where the lifestyle modification doesn't work, then medicines are available. I've just gone back to the chat just briefly, just because I didn't want to lose these topics. So we've had a few questions about intermittent fasting and 5-2. I hope I've addressed that. That intermittent fasting is that you, throughout the 24 hours, you intermittently fast. So maybe for, so I said 8 of those 24 hours you'll eat, and the other hours you're not eating. So you're training your body to eat over certain periods of time, and then you're digesting your food and you're metabolizing things over certain periods of time. And it means that it's just restricted eating, and it does lead to a significant amount of weight loss. Somebody said that exercising 3 times a week, still increasing weight, then you got to consider what exercises you're doing. Weight training is very good for weight loss. So walking and running is good, but you need to be doing some strength training exercises, because that certainly helps to reduce weight, because when you gain muscle, you are actually, your muscle mass increases, and that you burn calories when you are more muscular, because you've got higher muscle mass. So that's important, not just to do walking and running, but to do some weight exercises too. And if you're exercising 3 times a week, but not eating the right things, I've certainly experienced this. Like they say, you can't run away from a good diet. So unfortunately, exercise isn't enough. We've also got to work hard at what we're eating as well as exercising. So yeah, I'll have a look at the questions intermittently as we progress. So we've kind of gone through diabetes. I'll touch on HRT. A lot of women use HRT to help with menopausal symptoms. And HRT medication is hormonal, so it's estrogen and progesterone. Obviously, we know that from the age of 54, women go through natural menopause and estrogen levels drop. And it really is significant. There are some women who I see in clinic who really struggle with menopause, particularly with mood changes. I've heard of some women say that they've had to leave their house because they're afraid of how bad their mood is and the effect it would have on their husband and children. It can be quite severe. So women do manage this with tablets, medication, patches, and it does help a lot of women in terms of their mood, hot flushes, but just like anything, and particularly hormones, there are side effects involved, which can be difficult for some women to tolerate. However, these side effects do tend to reduce over time, particularly over the first 3 months of using HRT. There are risks with HRT, like blood clots, cancers and stroke. However, the cancers, particularly female cancers, womb cancers, ovarian cancers, the risk is only slightly increased with HRT. Things like blood clots and risk of stroke can occur, but they usually occur in people with other factors, other pre-existing risk factors that can increase your risk of these conditions. So certainly speak to your GP about that. Apart from hormones, there are other things that women can use to help with menopausal symptoms. I think people really minimize the effect of lifestyle changes when it links with menopause. So that's things like more sleep, changing your diet, use of vitamins, and other things that can help improve your diet. And also there are non-hormonal and herbal preparations as well that you can consider when it comes to menopause. So when we are going to look at endometrial cancer or womb cancer, I'll just go on and talk about that shortly. One of the first signs of endometrial cancer is bleeding after the menopause. So you get to the menopause around age 54, and usually you'll stop having periods between 52, 56, and you'll have at least 1 or 2 years of no periods. And then some women may see their GP because suddenly, after a few years, they've suddenly had a bleed. Obviously, it's abnormal, and you definitely need to see your GP if you suddenly have a bleed after the menopause, because that needs investigation. Sometimes some women find that they have bleeding even before their menopause. They have bleeding in an erratic way. Perhaps their cycle is every 28 days, and suddenly every 2 weeks they're having a heavy bleed, and it's abnormal for them. I think even in these situations, it's important to see your GP and review that. I'm really happy that we've got some male members in the audience enjoying the presentation. Absolutely. All the male members, you've got sisters, you've got mothers, you've got friends who are female. So yeah, it's important. Thanks for that encouragement. Some women may also describe an abnormal vaginal discharge. So that also needs investigating too. Right, so investigating. So women usually, if they've had abnormal bleeding, they'll go and see their GP. Their GP will usually arrange for an ultrasound scan. And then I, as the gynaecologist in hospital, will see the patient, review the symptoms, review the scan. I'll have a look at the lining of the womb, so the thickness of the womb lining. And the thicker the womb lining is, the more concerned I am as a gynaecologist about either pre-cancer or cancer of the womb. A woman then gets an examination by myself or one of my colleagues, and we'll do a little biopsy, which we can do without anaesthetic. Some women find it a bit uncomfortable, so can use anaesthetic. And it's a womb biopsy using a very little, long, thin, almost like a vacuum tube that goes within the cervix, like I said earlier, the neck of the womb, into the womb, and we take a tiny bit of tissue, and that can be sent to the lab, and we can get an answer within a few weeks. Some women end up needing MRI scans if they're concerned about the findings as well. And that's it really in terms of investigations. Once we've had the results from the biopsy, it will tell us whether we're dealing with pre-cancer or cancer of the womb lining. And when we do have women with cancer, they'll usually be discussed what we call a MDT, like a multidisciplinary team meeting. And we talk about their management, which is usually centered around these 4 areas. So some womb cancers, particularly with women who can't have surgery, can be managed with hormones. And that's usually a hormonal coil called the Mirena coil. Other hormonal coils are available, but that's the one we tend to use in the UK. And that releases a hormone called progesterone. which thins that womb lining. So like I said earlier, usually with womb cancer, it's a thicker womb lining. So this hormone acts directly within the womb for at least 5 years. It can actually thin the lining and reduce the cancer progressing, and women can use it for years and they're fine. But the gold standard treatment for womb cancer is surgical treatment, and that's a hysterectomy. I do hysterectomies maybe on a weekly basis, and we are getting to the stage now with hysterectomies where we are doing them keyhole. So I'll do a keyhole procedure. Maybe 5 abdominal incisions, about 1 centimeter. In some units, women go home the same day. It's a very satisfying procedure. It takes about 2.5 hours. Women go home the next day, and that's it. That's literally all the treatment that 90% of women need. Obviously, there are some women who need further treatment, and that's usually in the form of radiotherapy or chemotherapy. And that's usually driven by cancer centres. And like I said, most women are treated with surgery alone. So living with womb cancers, we do find that if it's a stage 1 womb cancer, which most of them are, 90% of women are completely cured, and that's it. Stage 2 womb cancers, which means that the cancer has spread to the full thickness of the womb. So earlier we talked about the womb lining. You've also got the muscle of the womb. Most cancers just literally stay within the inner lining of the womb. Some cancers do progress to the muscle. So we find that the stage 2 cancers, when it's progressed to the muscle, then 75% of women survive over 5 years, and surgery may be all that's required. In a very small number of women with stage 2 womb cancer end up requiring radiotherapy. We've also got stage 3 womb cancer, and when the cancer's progressed beyond the womb and it's invaded some of the lymph nodes in the pelvis, and these cancers are usually treated at the cancer centres and will require surgery on the lymph nodes and also some radiotherapy. And women with this stage of cancer tend to go on, 50% of them survive over 5 years. But like I did say, so reassuringly, most womb cancers are detected at the stage 1 stage. Stage 4 cancers are rare, and unfortunately only 15% of women survive over 50 years. But as I said, they're very rare. And yes, thanks for the comments about advances with surgery. Absolutely. I mean, certainly something I particularly enjoy as a surgeon. So I enjoy new equipment and new devices to help with womb cancer surgery, and it's great to see different advances available and different technology that can be used to help women recover from surgery very quickly, and that can also be used from the medical side as well. So that's great. Right, so let's go into something a bit more topical. So we've gone through womb cancers. I just thought we'd touch a bit on hair relaxers, because that's been in the media recently. So some of us may have seen this film. I've seen it a couple of times. So Chris Rock, as we all know, is a modern comedian, and he produced a documentary a few years ago, I can't remember the exact year, called Good Hair. So I guess, what does it mean to you to have good hair? Something to think about. What does it also mean when your child asks you, mummy or daddy, is my hair good? Do I have nice hair? Do I look like I'm trying to think of the girl from Frozen that my kids seem to like. I can't remember her name, but yeah, do I look like any of the girls? Which I tell my girls, no, you look better than them. You're not a blonde princess. You've got beautiful black afro hair. Elsa, thanks, Natasha. That song, that name I hear regularly through the week. Do I look like Elsa? I said, nope, you look better than Elsa. Your hair's better. So yeah, I feel it's really important, particularly with Black African young girls. I've got 2 who are 6 and 3. I tell them that your hair's better than Elsa's. So yeah. Right. So some of the words that are used in beauty relating to African hair, Afro-Caribbean hair, I feel can be quite emotive. So words like wiry, coily, kinky, nappy, difficult, I find that these words can be quite negative. And essentially, this is why years ago, hair like this was looked down on, and hair like this on the right was preferable. So I looked into the history of them. So actually, relaxers were used over 100 years and years ago. So in 1900s, used on a sewing machine. So there was I forgot the name of the guy again. So he was creating fabrics, and he wanted to get less friction on the sewing machine as he was creating clothes. And he found a product that eased the glide of the material over the sewing machine. And after using the product on the sewing machine, he then used it on a dog to see how it would affect the hair on a dog. And lo and behold, the hair straightened. And he found that he could market this product. And here we are in 2023 with many people using hair relaxers to help manage their hair and to change the structure of their hair. Hair relaxers essentially damage the natural protein structure in the hair, and some people find it makes their hair care easier. Unfortunately, there are risks with hair relaxers. So I'm sure we all know of that time. I certainly had relaxers from probably the age of 13 till about 21. I remember those burns when you'd feel your scalp burning with the relaxer on. I certainly had a bit of alopecia at the back, where perhaps the relaxer wasn't applied properly. You can get dependent on it. So some women find that they're using it every 4 weeks rather than every 6 to 8 weeks because you feel like you need it every time those roots are coming through. It can lead to dryness and brittleness and over-treatment, because the relaxer has been produced to be used on afro, the thicker hair that's coming through at the root, not to be applied to the already processed hair. So sometimes you can over-treat if you are applying the relaxer to pre-treated hair. Al Sharpton had a really good phrase, and this is the social impact of relaxers. He said, we wear our economic oppression on our heads. And essentially he was saying that relaxers are linked with, colonialism, this colonial mindset that straighter, longer hair is better and it's more presentable. And Al Sharpton said that women are applying this to their heads. They're applying that colonialism, that sense of European is better. You're applying it to your head when you wear the relaxer. So, historically it was seen as more acceptable, and it still is, I guess, these days in some communities. Some people certainly do feel that it is more acceptable to have straight hair, and that's whether you're wearing relaxer, wigs, weaves, that kind of thing. And it's difficult. It is controversial. I fully appreciate that. It's a difficult area. Some people feel that you're accepted better. People feel that they can tolerate their hair better when it's straight. Some people feel it's more professional. And we've got to realize that apart from the scientific research that's come out about relaxers and the social and the political views, that it's actually a really huge industry. So marketers are pushing these products on certain communities because many people buy them, and it's a huge industry. You've got impressionable people who are younger or teenagers, and we have people who continue to use these products, and it's financially quite lucrative. So research has been produced, and first of all, the Crown Coalition, which is a group in America, did some research and some market research essentially, and found that Black women were more likely to feel that going to a job interview with straight hair, they're more likely to be successful, which is sad. I find that to be quite sad. But again, that's the views of many, many women. Some Black mothers like myself have definitely found that their children, particularly their daughters, have experienced racial discrimination because of certain hairstyles. Some women have been sent home from work because of their hair, and we've certainly seen that in BBC News over the past few years on what's deemed as professional and what has been deemed as distracting or unacceptable. Again, these are terms used by people outside of our communities, and when it comes to describing and defining or potentially controlling our hair and the way we present ourselves. And 44% of Black women under the age of 34 have felt pressured to do a headshot with straight hair rather than their natural curly African hair. Somebody just asked about whether this research on relaxers affects men, and absolutely, it's the chemical within the relaxer that's affecting hair. So that's hair, whether it's growing on a man's head or hair that's growing on a female head. Yeah. So the big study that came out, and this was a few years ago, was called the Sister Study. This was published by the National Institute of Health, so it was a reputable publication. And you've got over 33,000 women within the age of 35 to 74. So it's a huge age range. The important thing is that 60% of these women were Black women. I think the other 40%, some were South American, mixed race, etc. But 60% identified as Black women. So these women were followed up for 11 years, and all of these women said that they use relaxers at least 4 times a year. So so we found that amongst these women, so we've got to remember that there were 33,000 women. They found 378 new cancers. So that's about 10% of them. Sorry, less than 10%, about 1% of them had new cancers diagnosed within that 11-year period. I guess some people would probably ask, oh, maybe something else caused their cancer, but they did account for these confounding factors and other variables, but we did find that within that cohort of women, you got new cancers. And they found that women were twice more likely to develop cancer because of the use of hair relaxers. So they looked at the hair relaxers and they wondered why it was, and they found that there are carcinogens. A carcinogen just means a cancer-causing ingredient that increased hormone levels, so increased your estrogen levels within the blood, and therefore increased the risk of cancer developing. And they also found that women were leaving these products on their hair longer than advised, and therefore exposing themselves to more carcinogens. This research was really interesting because it was the first piece of research carried out on a large scale relating to hair relaxers. I think some women found it quite shocking because they didn't know. There was prior to this, and I think this was also mentioned in Chris Rock's documentary, there was evidence relating to relaxers and fibroids. And obviously within our speciality as gynecologists, we do know that fibroids do increase your risk of cancer. And not by a large amount, but there is a link with fibroids and cancer. So it was quite surprising for a lot of women and a lot of gynecologists to find that it wasn't just fibroids, but actually the medications in these hair relaxers are directly linked with cancer. And it's quite concerning. So alternatives to relaxers for people who are interested, I mean, there are things like keratin treatments, which are protein treatments to the hair, thermal straightening, twisting, plaiting, or locking your hair. So that alternative ways to manage your hair and not feel that you need to have relaxer. So I guess the question is now what happens? And I think the evidence is going to continue to grow in this area. That's the first piece of research. And I think other people are going to do similar research on it. I think there'll be research on the different types of relaxers. I think some women will really reconsider the use of hair relaxers and consider alternatives, because there is a huge move now within the natural hair space, as some people call it. And then, consider embracing natural hair and consider ways of presenting or managing their natural hair to reduce the risk of cancers and other things in the future. I just wrote a few lyrics from one of Jill Scott's songs called I Am Not My Hair. So essentially, obviously our identity is not within our hair, but obviously we know that particularly for women, hair is a huge way of how we present ourselves. I will send a link about the sister study. Once we do Q&As, I'll find it and I will pop it on the group chat. I also did some research and I couldn't find any other larger studies linked with hair relaxers, because I thought, is this the only paper? But actually 2023 now, this seems to be the only paper relating to hair relaxers and endometrial cancers. But I do think we'll have more of them. And I think the study was presented last year. So yeah, but I think there'll be more research that will be coming out in the future. Somebody's asked about wigs. There's no link with endometrial cancer and wigs because you're not changing your hair underneath. But obviously wigs do have that obvious social factors of why are we covering up our natural hair, some people would say. There are no wigs used in the world with Afro hair that are used on a daily basis. The only wigs with Afro hair that are used to make fun of people from the Afro-Caribbean Society. Nobody puts a wig on their hair of Afro hair. It's only people in the Afro-Caribbean Society that wear wigs of European or Brazilian hair and do this on a daily basis. But nobody does that for us. So I find that quite interesting. Right, so the most important bit of the presentation is how are we going to reduce our risk of womb cancer? So aside from hair, let's look generally at womb cancers. So I hope you've got from this presentation, the most important thing is to keep your weight in the recommended range, and that is by regular physical activity. So find something you like to do it little and often. It has to be something you like. There's no point saying you're going to go for a run when you don't like running. So start with a walk, start with dancing, start with any kind of aerobic exercise, which increases your heart rate, gets your heart rate going, gets you short of breath, and then you've hit it. So start with 10 minutes a day, increase to 20 minutes a day after 2 weeks. And there's also some evidence that having children reduces your risk as well. Obviously, that's not completely in our control. And that's because you are reducing the number of times your womb lining has been shed and reducing the number of times your ovaries are ovulating. And that's the same with the pill. The Mirena coil is hormonal, and a healthy diet. So any diet that's linked with improving your metabolism, any diet that's linked with low carbohydrate, low sugar is going to reduce your risk of womb cancer as well. Somebody asked about shampoos and hair conditioners. I don't know about any evidence with womb cancers with those. Obviously, I'm sure there might be some things out there, but nothing that I know about. Reducing your risk of female cancers, it's similar really. So physical activity, healthy diet. So I'd strongly recommend the intermittent fasting or the 5-2 diet, because you are restricting the amount of time period that your body is exposed to certain foods, and you are controlling that in a better idea. That Natasha's putting a thumbs up for intermittent fasting. Maybe you're a fan like me. I'm a huge fan of intermittent fasting. I think it's great. I think it's good for self-control. It's good for discipline. It's good for your metabolism. And I think that unlike many other diets, it's literally one you can continue for life. Many diets are good for a short period of time, and as soon as you stop it, you put the weight back on. But intermittent fasting it's pretty good for life. Other ways of reducing your risk of female cancers, smoking and alcohol. So not smoking, because smoking is linked with cervical cancer. Use of alcohol, reducing that, and also genetic screening if you have family members who have genetic conditions that could increase your risk of cancer. And there's just a few of my references, and that's it. Thanks so much, everybody. I'll just stop sharing and I'll find the link to the article now. Thanks. I don't know about hair dyes, I'm afraid, and endometrial cancer. There might be some evidence out there, I'm not sure.
Brilliant. And thank you very much, Dr. Joanna. We've got a couple of questions. I think you've touched on some of them in the chat, but I will crack on. So the first is, I think you may have touched on it, but about fibroids and the prevalence in Black women. And, if you can touch a bit more, in terms of prevention. I don't think we know much about how we can prevent that, but then, you may have touched on the link between the chemicals, we in air products and then the fibroid growth, because I know with some women in my church or, friends who have had surgery and then, that's come back again.
Both fibroids have come back.
Yes.
Yeah, yeah. Unfortunately, that can certainly happen with women with fibroids. The thing with fibroids, we've got to remember that less than 1% of them will come back with cancer. So many of them are just benign muscle growths in the womb lining. The issue with fibroids is the symptoms it causes. So it's that pain, heavy bleeding, and that really disrupts a woman's daily life. So imagine not being to leave the house because you're afraid you're going to flood through multiple pads, not being able to work because you're going to be cramped with pain, not being able to move about because every time you stand up, you don't know whether you're going to flood. I mean, it's hugely disruptive to a woman's life. I can't remember the exact incidence of fibroids, but we all know that there are more common in women of Afro-Caribbean descent. We know that they are linked with cancer, but very, very unlikely. Like I said, it's about 1%. So that's why lifestyle factors are so important. Obviously, we can't eliminate the fact that genetically we're more prone to be having, it's not genetically, that ethnically we are more prone to have fibroids, but we can address things like obesity, diabetes, and hormones. So if we can address these along with having fibroids, then that helps to make us healthier. I think any kind of HRT is going to increase your risk of fibroids. And if you do have fibroids, the hormones within HRT can cause them to grow more. So that's something to consider as well.
Yeah, thanks, Doc. And also clearly there are links with difficulties in conceiving.
Oh, I know. Yeah, that's the most traumatic factor for particularly for women of childbearing age when they're struggling to conceive. And I think that's another topic on its own to present, but it's really important that it's not just the fibroids themselves, it's where they are, the number of them, the size of them. So I think, first of all, by visiting your GP and then being referred to a specialist, it's really important to get the information about your fibroids. So it's not just anyone's fibroid, it's what's happening in your womb. Get the right scans, the right investigation, and then get the right care that you need as soon as possible.
Thanks, Dr. Joanna. So it will be good to have you back just to talk about fibroids and pregnancy.
Yeah, that's fine.
Yeah, brilliant. So the team will note that. So, someone is putting in the chat about losing confidence because of weight gain. And I wonder if you can give some reassurance and some helpful tips.
So yeah, I think that's really difficult. Weight gain, being overweight and obesity, it's a chronic thing. I think we can trivialize it. And I think society makes it really hard for people who are particularly overweight to try and reduce weight. Because first of all, it's your sense of body image. It's a sense of how you see yourself. It's a sense of how you feel you can change. And I think addressing that is first of all important. So a sense of self-worth, a sense of self-value, that you are not your weight. Your weight doesn't define you. Your weight can obviously have health consequences, but your weight is controllable. So telling yourself each day that I am not my weight, I can manage this, I will seek the tools to reduce my weight and live a healthier lifestyle. So self-talk is very important, just like with any chronic health condition. So telling yourself, I will seek these tools, and then just doing it. So like I said earlier, there are some exercises that might be difficult. So if you feel more self-conscious outside, you can go for a walk. So nobody is going to say anything of, people can be quite self-conscious, but going for a walk is going to put less pressure on your knees and joints, particularly if you are overweight. And you will find that over weeks, your tolerance, your what we call exercise tolerance, or the distance at which you can walk increases with time. So that's a really quick win, as we call it, for people who are overweight. So apart from self-talk, it's also important to have support. So weight management is really difficult to do on your own. So whether you have a few friends and you have a WhatsApp group for accountability, and we say, okay, every Wednesday we're going to go for a 30-minute walk together, we're going to talk, or we're going to pray, or we're going to sing, or whatever, really, as a group. Make it a group effort, and you can be accountable with people like this. And then you say, we're going to do this, and you stick with it. And then when you do it once, you'll find you enjoy it, you get endorphins being released, and then you find you're more likely to keep doing it. So I think self-talk, group activity, find something that you like and stick at it and get support. I'd say that.
Right. Thanks a lot, Doc. And yes, for those who want more on nutrition and physical activity, then there's a virtual session every Tuesday. So if you drop us an email, healthaccount.org.uk, we will share that with you. But I think there's real value in that peer-to-peer support. So you don't need to be a member of a gym. What doctor is suggesting is you can get a few friends and go on a healthy sort of challenge and self-motivation. Brilliant. So the next question, and also we've had some very positive feedback about the presentation. So thanks, Doc, for that. So I know you've touched on this, but someone who, and you did touch on the menopause, and this person is saying, she tries to exercise, and after the menopause, she still finds herself putting on weight, and now even after this talk, she's concerned about, the possible sort of risk and link to cancers. I just want that.
Yeah, I think, well, first of all, let's try and remember, I don't want to catastrophize, because we've got to remember that womb cancer is the 4th most common cancer. So we've got other cancers that are more common. Womb cancers, again, it's not a common cancer, first of all. So that's first of all. And secondly, I think the lifestyle factors are most important takeaway from this presentation. And those lifestyle factors, it's not just about cancer, it's about heart disease, diabetes, obesity, like we've spoken about. And once we manage those, we reduce the risk of health conditions in the future. Cancer is just, but cancer is one consequence of unmanageable health conditions. So womb cancer is not common. And womb cancer, when women do get it, it's manageable. It's not a condition that people die from often, because most of it is surgically managed. And like I said, 90% of women are living cancer-free after 5 years. It's probably one of the best cancers, I guess, to get, because it's easily treatable. The most important thing is we are addressing our health issues that could lead us to have heart disease, which doesn't just last for 5 years. Heart disease will last for 10, 20 years if it's not managed well, and then can lead to untimely death. Hypertension can last for decades and could lead to untimely death. So cancer isn't the issue. It's these chronic health conditions that you can live with for a long time that are difficult to manage. The cancers that some people get as a consequence can be managed quickly, and women live well with it after the management. But it's the other health conditions I think are most important.
Great. Thanks for that, Doc. I think, some of the history you mentioned and some of the research, the sister study, one of our amazing doctors from the Cameroon community has asked for the link. But I've also put it on. You've put it on. Brilliant. And I've also tweeted the quote from Al Shap. And then I've mentioned him. So if you're on Twitter, we can, link you.
Oh, great. Yeah.
So yes,
I love that.
Yeah, it's just amazing. So just want to find out, because I know someone was asking about hair dyes, shampoos, conditioners, and there will be a range of this out there. What should people look out for, and how can people try and mitigate the risk of using sort of chemicals that?
Yeah, I think it's difficult. I will find that, I think there are 4 carcinogens within the hair relaxers that were quite problematic, but I don't think they're found as commonly in hair dyes. I can do another brief look at the evidence relating to hair dyes and see if there are any carcinogens or concerns, but I don't know of any evidence with womb cancer and hair dyes particularly. I think it's quite important to also always consider natural options. So whether it's hair dyes or any chemicals or HRT, it's always good to consider natural options like henna, or other ways to color your hair naturally. And that way you're eliminating the chemicals that can cause harmful problems. So yeah, considering natural alternatives is very good.
Thanks, Doc. There's a question here about early, sort of menstruation at an early age. Did you say it has a link to cancer?
Yeah. So again, when it comes to any kind of cancer, we look at risk factors, all risk factors. We can't control the age at which you start your periods as a girl. You can't control the age at which you stop your periods. So that's out of control. They've just found that amongst women with womb cancers, they have seen that they've started their periods early or they've ended their periods late. So it's uncontrollable. It's just one of the factors that's been found. And like I've been saying, we have to control the things that are within our control. We can't alter that at all. So controlling weight, blood sugar, blood pressure, that's of more importance than being concerned that you started your period at the age of 8 or 10 or whatever. That's beyond our control.
Yeah, no, thanks. That's really interesting. As a father with 2 daughters, I mean,
Yeah.
what would you advise me to do? Should we speak to the GP and get an appointment, or what?
I think only if it's affecting the child. I mean, I think I do know some girls that are starting their periods at the age of 8, and I think it does change, particularly with Western diets and processed foods. I think that there's a strong link with that. I mean, I would only see the GP if a young girl is struggling with heavy periods and maybe needs some hormonal control, or mental health, things like that. Or if particularly she's bleeding heavily and it's causing her to feel very tired, that could be a sign of anemia, and she may need medication or other things to help with that. So I'd only really see your GP if it's causing secondary problems such as that. But in terms of, thinking, oh, my child is 8, she started a period, she's going to get womb cancer. No, it's not a direct link. It's just one of many risk factors with womb cancer. Many girls who start their periods early do not get womb cancer because of other factors in life. You don't know, a girl of 8, who knows what's going to happen in 30 years' time. She may be a very, very young, healthy girl and never have any issues at all. So it's just one of the factors that's been detected, really.
Great, thanks. That's reassuring. So I'll not be worried.
No.
But just stick to a healthy life.
Yeah, absolutely.
Brilliant. Yeah. So for those of you on Zoom, lots of chat in the, lots of exchanges in the chat box. Gertrude, who sometimes hosts these sessions, she's leading on a cost of living crisis survey. We just want to understand how that plays out for our community. So, whether it means you're not able to have a healthy diet and other things, and please make sure you give some feedback. But also we have one of our long-term nurses who is talking about HRT and that can protect from osteoporosis and heart disease. Any reflections on that?
Yeah, I mean, HRT is not the enemy. There are some women that find it to be essential. Like I said, there are some women who really struggle with their moods or with their hot flushes, sleep, concentration, brain fog because of estrogen deficiency. And we've definitely have evidence now that how estrogen affects the brain. And, to the men out there, can you imagine being 45 at work and just having a complete brain block and it happening every day to you and not being able to function? That must be so frustrating. And unfortunately for women, it's beyond our control. That's just what estrogen deficiency does to different parts of the body. So some women do feel that they need that hormone, that boost for a period of time to help them. And that's completely understandable. And there are benefits to HRT, mood, sleep, cognition, bone protection, absolutely. I guess on balance, we've also got to consider non-hormonal methods. So for bone protection, you can see your GP about calcium or other drugs that could help. The other thing that is in the news now is weight training. So any kind of muscle training. So you strengthen your muscle, you strengthen the bones, and that's a great way of reducing osteoporosis. That's because you're getting stronger, your balance improves. You're less likely to fall because of your strength and balance and muscle tone. So in addition to HRT, just like anything we've been saying, this exercise, manage your weight, manage your blood sugar, and not just walking and running. When women are over 40, our bone mass, our muscle mass reduces. So we've got to top that up, not just with HRT. It's, you don't even have to go to the gym. If you've got tins of tin tomato, which we all have, as many Afro-Caribbean women in our cupboards, tin tomato, a couple of days, a couple of times in the day, 2 tins of tomato, a few bicep curls, that's good because it improves your muscle mass. Any kind of 10-minute exercise on YouTube, just like muscle training or strength exercises, just to improve your muscles, improve your muscle and bone health, and very, very helpful. So yeah, HRT is not the enemy. I would use it for a short period of time. If you have a womb, I'd also recommend you're using the estrogen with the progesterone. But I would give it a short period of time, maybe 5 to 10 years, and then stop. Just use it to get over that hump, particularly mid to late 40s, early 50s, when you are struggling with those symptoms, if they're really unmanageable. Low dose of estrogen, use for a short period of time, manage as well with the other lifestyle changes, and it can be very, very helpful for some women. Is HRT linked with breast cancer? There was a big 1 million women study about HRT and breast cancer. It found that using HRT, it doesn't increase your background risk of breast cancer compared with the background population. But if you have a family history of breast cancer, then you need to see your GP and consider the benefits and risks of using it. But yeah, not on its own increase the risk of breast cancer, no. And somebody else asked metformin. If you're diabetic, your GP suggested take metformin. I'd still continue. But like I've been saying, diabetes is one of those conditions that can be managed, alongside metformin. You need to make sure you are doing your utmost in terms of exercise and dietary modification. You may find that intermittent fasting, 5-2 diet, things like that can also help your blood sugar control as well.
Yeah, thanks, Doc. You're talking about blood sugars, and I'm just wondering how people can avoid, whether it's avoidable, gestational diabetes.
Yeah, I used to do a lot more obstetrics than I do right now, but gestational diabetes can be managed and can be prevented. So the first area of managing gestational diabetes, like we could say this all along, diet and exercise. It's the secret for many things. So usually when a woman is diagnosed with gestational diabetes, usually it's around after 28 weeks they have their diabetes test. You're given 2 weeks and you're usually given a little book, and you test your blood sugar at various times in the day. And over 2 weeks, you're advised to keep an eye on your diet. So definitely gestational diabetes, I think about 60% of women can manage it literally just by controlling what they're eating. One of the ways of managing diabetes is exercise after a meal. So after an evening meal, for example, 10 to 20-minute walk will reduce your blood sugars and help your body to control that a lot better. So many women do manage gestational diabetes just with diet alone. Some women need metformin and some women need insulin as well. So it varies, but yeah, I would strongly suggest diet and exercise first of all.
Brilliant. Thanks. Thanks for that. So, I mean, you did touch on this early on, but you were advising people to be mindful what they see in the media.
Yeah, absolutely.
Just wondered if you can say that, because there are some on Facebook and YouTube as well.
Yeah, I mean, I think there's a lot out there now, and I think we've got to be careful what we read, and make sure that we're reading things from reputable sources, because there's a lot of scaremongering out there. A lot of people would advise on one diet or another. Not many things are evidence-based. Many things are experiential. So somebody has managed to lose, I don't know, 10 kilos over a certain period of time, and they're now saying that what they've done is the secret. And I don't think there is a secret. I think the basics of you're limiting your calories and you are being more active, and that's the thing. Limit your calories, you have good foods, and you're more active, and that's the only permanent thing that's going to lead to long-lasting weight management and weight control. And it's about finding an activity that you like. So, and for me, it's gym and dancing and things like that. For some people, regular walking or running can be helpful, but it's finding something that you like that you can continue with and having the support in doing that. So yeah, I'd say that.
Brilliant. Thanks, Doc. I think, lots of positive comments about the presentation and learning, and I've learned, a lot as well. We're looking at a paper we're looking at a paper at the moment that is exploring the link between slavery, colonialism, and sort of health inequality. So it will be great to get your input and your support. And a couple of people are looking forward to you coming back and doing a session on either the menopause, and there's another here on sort of the pregnancy and sort of fibroids and pregnancy as well. But I did promise Doc that we will make sure we let her go on time. There's a last question there. What is HbA1c number, T2 diabetic? With a change of lifestyle and exercise, can they get into remission? And then also someone asking about the possibility of developing diabetes after gestational diabetes. So those two, if you can finish with us.
Okay, great. Well, first one, I'm going to struggle to answer because I'm not a general practitioner, so I don't do HbA1c blood tests. And I don't want to throw out a number that's incorrect, but I'll definitely see your GP. And it's not just the number, it's the trend. So if you're finding that your HbA1c is increasing, that's not good. If it's reducing, you're doing the right thing and keep going. I think it's going to be very difficult to just manage diet and exercise when you've been on metformin for quite some time. That's going to take quite a drastic lifestyle change. It's not impossible, but that's going to be quite drastic in terms of maybe calorie reduction, reviewing your lifestyle. When you've been, I guess it also depends on how dependent you are on metformin, but I think that's certainly something you need to address with your GP, particularly if you want to come off metformin, which is good. But if you are going to come off metformin and you've needed it for a long period of time, then you're going to need some kind of drastic lifestyle changes to manage your diabetes, but not impossible. And Esther, I wish you all the best with that. And I think there's a link on nutritionists and dietitians to help in terms of healthy hearts, and I think that'll be very helpful for you. And about gestational diabetes, yes, so the evidence is that about 50% of women diagnosed with gestational diabetes, and gestational diabetes is essentially diabetes in pregnancy. So the thing about pregnancy is that conditions in pregnancy are usually a window to what a woman is going to develop in 20 years' time. And that's because your body is challenged by pregnancy and it exposes underlying things that you wouldn't necessarily know about until 20 years down the line. So gestational diabetes, we find that 50% of women with gestational diabetes will go on to develop type 2 diabetes in the future. That may not be for 10 years, 20 years time, but it does happen, unfortunately. And the good thing about gestational diabetes, it can be that kind of shock, that kind of challenge for young women to then think about, oh, how am I living? How am I eating? Am I exercising enough? And it can prompt women to actually develop a healthier lifestyle, lose weight, not just for themselves, but for their children, for their pregnancy and for life. So yeah, it's good. So there is that 50% number that we use when counseling women who are pregnant with gestational diabetes.
Brilliant. I think the final one is from YouTube, whether there's any link between PCOS and womb cancer.
Yeah, there is a link. Again, I can't give the figure. It's not very high, but we do find that women with PCOS, because they're not ovulating regularly, their womb lining isn't naturally shedding every month. And we do find that women with womb cancer, there are more with PCOS. But again, just like all of the risk factors I've spoken about, PCOS is linked with diabetes and obesity, and I'm not going to go on about it again. We've clearly got the message today about exercise and diet. Women with PCOS, many of them, I think it's about over 70% of women with PCOS can be cured just by diet and lifestyle. And it's literally just a metabolic imbalance leading to your periods not happening. So PCOS and polycystic ovarian syndrome. So your ovaries develop lots of cysts on them. The ovaries stop functioning normally. So then you're not releasing an egg every month. You're probably releasing an egg 3 or 4 times a year. Your womb lining builds up. and it causes what we call this metabolic syndrome. So some women tend to get excessive hair growth because of high levels of testosterone. Some women tend to have male pattern hair distribution or gain weight. And again, it's metabolic. So most women, if you manage the diet, lose some weight, they do find over a period of months that their periods begin to normalize, their cysts reduce, and that's usually the mainstay of managing. Some women do need metformin or other hormones, but usually, again, like we've said today, diet and exercise is key.
Brilliant. Dr. Joanna Abiola, we are extremely grateful once again for you giving me
It's
time,
been great.
you know, on a UK summer, you know, sort of weekend. And we look forward to having you back to do sort of two pieces, one on the menopause, and then we can also look at, you know, sort of fibroid pregnancy and how we support. And also just to say to you all, it's been brilliant. We've had over sort of 230 people join throughout the session. You know, these sessions happen every Saturday morning. And for those of you who are encouraging your sons and daughters and brothers and sisters to go into medicine, then it's a good learning place. You know, it's a good place to learn, but also opportunities for, you know, volunteering, you know, to be part of the team that runs these sessions. So, you know, Doc, we're extremely grateful, and we hope you have a lovely weekend, and hopefully we will see you in person at, you know, the Con Gala in October.
Yeah, looking forward to it. Thank you. Thank you, everybody. Thanks for your time.
Brilliant.
Thanks,
Thank
Natasha.
you. So I shall hand over to Natasha and some, you know, who will get someone to give us some important announcements. And, you know, for those who live in Greater Manchester, Bob Expo is on at Old Trafford. So by all means, please, you know, go down and support Black-owned businesses. Over to you, Natasha.
Hi, Natasha, please unmute. We can't hear you.
Hello, all. As Charles just said, thank you so much for joining us today. Dr. Abiola was such a powerful presentation, so insightful, so relatable to all of us. You're touching a lot of things that are a bit taboo in our community, but everyone is really talking about it. So it's important to get these topics on a big room like this with so many people, and a safe space where we can pose questions and you know, interact with each other. So thank you so much for that, and thank you, Charles, for moderating the session so well. I wanted to just let you know and invite you as always to join us for a CATIP Health Hour for CATIP Health Hour next week, Saturday, 5th of August, 2023, obviously at 11 o'clock. Don't miss out. Very special session on contraception and sexual health. We'll have Dr. Margaret speaking with us, and we are honored to receive her. So don't miss out. We really look forward to welcome you then. We have our family and advocacy support sessions every second Wednesday of the month at 6 o'clock. So it's in the evening. It's made in a way that is very accessible to everyone. So join us after work. I understand not everybody will be able to join, but it really is not it's an opportunity that you should miss if you have any. We help with the range of issues regarding a family. And this is on the 9th of August. And this Tuesday, there was a lot of conversation today about diet, nutrition, you know, where can I search for more advice or help? The answer to that is really our Healthy Heart session on Tuesday evening. Again, 6 p.m., we try our best to make it accessible to our community. We have our guest speaker, Jasmine Carbon, and the host, Dr. Hiba. And afterwards, we also have a physical instructor, Orlando, speaking with us. So don't miss out. As always, our sessions are free. Come join us and receive more knowledge about your health and your well-being, and how you can control your diet and weight and so forth. We've spoken, Charles mentioned it, I've mentioned it in the chat as well. There's a link there. We are very, very keen to know how you're dealing with the challenges of the cost of living crisis that are presenting to ourselves at the moment. We really want to collect this data. This is a Black-led research. So we will do our research really focus in the Black community and the needs that are in our community, what opportunities can be created, after this research. So please, this survey takes 3 minutes to do. I've done it myself. A link is on the chat, or use the QR code. And we have our counseling service. Number is on the screen, 07710022382. We are here for you. You're not alone. We offer obviously culturally and religiously appropriate specialist service. Our counselors are looking forward to speak to you. Again, it's a safe space, can be heard and be understood. And we are very happy to also have our green arts and wellbeing services. It's open to everyone. We have a Stockport hub and we have a Bolton hub. So this is face-to-face activities, arts and crafts, collage, painting, and you really study art in the way things can come to, why am I using words that are so hard for a Portuguese person? But basically you can, explore your artistic side. It's really for everyone and really helps with your mental health, for other people with other illnesses as well, helps you just keep healthy. And last but not least, we are looking forward for Black History Month. We have our civic event, the Manchester Cathedral, every year. So this is on the 28th of September. We're really looking forward to welcome you there. All of you are invited. At the moment, we are looking for stallholders to come and join us. So there is the email there. I also put it on the chat. So come and be part of this event with us. And we just wanted to, this is facilitated by Khan with the help of long-standing partners, Enfield Caribbean Association. Contact is on the screen if anyone wants to reach out, and the same is for all of them. RAFA International Development Agency, another one of our partners. The Royal Assembly Redeemed Christian Church of God in Sheffield as well. They had very recently a health conference. Croydon BME Forum, and also BHI Black Health Initiative. All of them are our longstanding partners. And if you need any of their contacts, just email us at help@con.org.uk. Thank you all so much for joining us today, and I hope to see you next week.
Quiet now. Okay, thank you. Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.